Lichen Planus, Pathophysiology, Clinical Presentation, and Management Strategies. Lichen planus is a chronic autoimmune inflammatory condition affecting skin, mucous membranes, nails, and hair. This article explores the disease mechanisms, clinical manifestations, diagnostic approaches, and contemporary treatment options. Introduction and Overview. Lichen planus represents a multifaceted chronic inflammatory condition characterized by an inappropriate immune response directed against the body's own tissues. Despite its misleading name suggesting a relationship to actual lichens, this dermatologic disorder operates through distinct immunological pathways that affect multiple organ systems. The disease typically manifests with characteristic lesions on the skin surface, though it frequently extends to involve oral tissues, nails, hair follicles, and other mucosal surfaces. Understanding this condition's complex nature is essential for clinicians seeking to provide comprehensive care and for patients navigating long-term management strategies. Pathophysiology and disease mechanisms. The underlying mechanisms driving lichen planus remain incompletely understood, though substantial evidence supports a T-cell-mediated autoimmune process. The disease appears to involve aberrant recognition of self-antigens at the dermal-epidermal junction, triggering infiltration of activated lymphocytes that produce inflammatory mediators. The initial trigger for this pathological immune activation remains elusive, with current evidence suggesting potential roles for viral infections, medications, contact allergens, and genetic predisposition. This heterogeneous triggering mechanism likely explains the variable presentation and course observed among different patient populations and may account for the difficulty in identifying a singular preventive strategy. Key points: T-cell predominant immune infiltrate concentrated at the basal layer of the epidermis. Production of cytotoxic mediators leading to keratinocyte apoptosis. Potential molecular mimicry mechanisms involving cross-reactivity between pathogenic and self-antigens. Impaired regulatory T-cell function contributing to sustained inflammation. Clinical presentation and morphological features. The clinical presentation of lichen planus encompasses a diverse spectrum of morphological presentations, though certain characteristic features appear consistently. The prototypical skin lesion exhibits a polygonal shape with flattened surface, characteristic violaceous coloration, and a fine reticulated white pattern overlying the lesion. In individuals with darker skin types, the lesions may demonstrate more gray-brown hues rather than the classic purple appearance. The dorsal surfaces of the hands, flexural areas of the wrists and forearms, the anterior lower legs, and the trunk represent the most commonly affected anatomical sites, though lesions may appear virtually anywhere on the cutaneous surface. Cutaneous manifestations. Skin involvement in lichen planus characteristically presents as numerous small papules that may coalesce into larger plaques. The lesions typically demonstrate the distinctive 6PS characteristic of the condition: planar, flat-topped, polygonal, purple, pruritic, papules, and plaques. Pruritus represents a significant clinical feature, with many patients reporting substantial discomfort that can impact daily functioning and quality of life. The chronic nature of cutaneous lesions means that patients often experience extended periods of visible skin changes, leading to potential cosmetic concerns and psychosocial effects. Some patients develop hypertrophic variants with prominent scaling, while others experience more subtle lichenoid changes. Oral and mucosal involvement. Oral lichen planus constitutes one of the most prevalent manifestations of systemic disease, with the buccal mucosa, tongue, and gingival tissues representing principal sites of involvement. The intraoral presentation frequently appears as a white reticulated pattern, though erosive and atrophic variants can cause significant pain and functional impairment. Patients with oral involvement frequently report discomfort during eating, drinking, or speaking, which can substantially affect nutritional status and communication. The relationship between erosive oral lichen planus and malignant transformation has generated considerable clinical interest, though the actual risk appears modest. Accurate diagnosis and regular surveillance of oral manifestations form important components of comprehensive disease management. Nail and hair involvement. Lichen planus affecting the nails, termed ornicial lichen planus, manifests through thinning of the nail plate, longitudinal ridging, and potential permanent scarring of the nail matrix. In severe cases, nail destruction can progress to complete loss of affected nails, creating significant functional and cosmetic morbidity. Hair follicle involvement, known as lichen planopilaris, represents a scarring alopecia that results in permanent hair loss in affected regions. These variants typically indicate more severe systemic disease and often correlate with significant pruritus and discomfort. The irreversible nature of follicular and ungual damage underscores the importance of early diagnosis and aggressive treatment in patients demonstrating these manifestations. Diagnostic approaches. Diagnosis of lichen planus relies upon clinicopathological correlation, combining characteristic clinical features with confirmatory histopathological findings. Clinical examination alone may suggest the diagnosis based on morphology and distribution patterns, but definitive diagnosis typically requires skin or mucosal biopsy. Histopathological examination reveals a distinctive pattern of interface dermatitis with lymphocytic infiltration at the dermal-epidermal junction, commonly described as sawtooth or lichenoid appearance. Additional findings typically include orthokeratosis and varying degrees of hyperkeratosis, along with evidence of basal layer degeneration. Immunofluorescence studies may demonstrate linear IgM deposition at the basement membrane zone in some cases, supporting the autoimmune nature of the disease. Key points: clinical examination demonstrating characteristic purple, polygonal papules and plaques. Skin or mucosal biopsy with histopathological confirmation of interface dermatitis. Direct immunofluorescence showing basement membrane zone deposits. Differential diagnosis exclusion of other lichenoid dermatoses and drug reactions. Therapeutic management approaches. Current management strategies for lichen planus focus on symptom control and inflammation reduction, given the absence of disease-modifying cures. Treatment approaches typically follow a stepwise escalation protocol beginning with topical interventions for limited disease and progressing to systemic agents for extensive involvement or severe symptoms. The choice of therapy must balance efficacy against potential side effects, particularly considering the chronic nature of many cases requiring long-term management. Patient education regarding disease chronicity, potential relapse patterns, and realistic treatment expectations forms an integral component of therapeutic success. A personalized approach considering disease extent, severity, patient preferences, and comorbid conditions guides optimal treatment selection. Topical and intralesional therapies. Topical corticosteroids represent first-line therapy for limited cutaneous disease, with potent formulations typically required given the inflammatory nature of lesions. Cream and ointment vehicles generally demonstrate superior penetration compared to lotions, with ointment bases providing additional hydrating benefits. For oral involvement, topical corticosteroid suspensions or gels applied directly to affected mucosa offer targeted therapeutic benefit with minimal systemic absorption. Intralesional corticosteroid injection provides an alternative approach for localized, resistant lesions, delivering high local drug concentrations while minimizing systemic exposure. Non-corticosteroid topical agents including retinoids and calcineurin inhibitors demonstrate therapeutic efficacy in selected cases, particularly for patients requiring corticosteroid-sparing approaches. Systemic pharmacologic interventions. Patients with extensive cutaneous involvement, severe oral disease, or significant systemic manifestations frequently require systemic therapeutic agents. Oral corticosteroids serve as traditional second-line agents, effectively controlling inflammation but carrying risks associated with prolonged use. Retinoid compounds, particularly acitretin and isotretinoin, demonstrate efficacy in resistant cases and may offer steroid-sparing benefits. Antimalarial medications including hydroxychloroquine have shown clinical benefit in certain patient populations. Immunosuppressive agents such as azathioprine, mycophenolate mofetil, and methotrexate provide alternative approaches for resistant disease or situations requiring steroid dose reduction. Emerging evidence supporting biologic therapies, particularly TNF-alpha inhibitors, suggests expanding options for refractory disease, though further research continues to define optimal patient populations. Procedural and adjunctive treatments. Procedural interventions offer valuable options for patients with localized disease or those inadequately responsive to pharmacologic approaches. Phototherapy utilizing narrowband ultraviolet B light demonstrates efficacy for widespread cutaneous disease, often combined with systemic agents for enhanced benefit. Excimer laser therapy provides targeted treatment for localized lesions with favorable safety profiles. Topical photodynamic therapy represents an emerging approach showing promise in early investigations. Mechanical approaches including microneedling and superficial chemical peels may offer cosmetic benefits for post-inflammatory sequelae. These adjunctive strategies often facilitate reduction of systemic medication requirements, thereby decreasing cumulative toxicity exposure for patients requiring extended treatment periods. Long-term management and follow-up considerations. The chronic and potentially recurrent nature of lichen planus necessitates long-term management strategies extending beyond acute symptom control. Regular clinical monitoring allows early detection of disease progression, recognition of treatment inadequacy, and assessment for potential complications. For patients with oral involvement, surveillance for malignant transformation, though rare, represents an important component of ongoing care. Patients should receive education regarding potential relapse patterns and the importance of prompt reporting of symptom changes or new manifestations. Periodic reassessment of treatment regimens ensures continued appropriateness as disease activity fluctuates. Coordination with other specialists including rheumatology may benefit patients with suspected systemic associations or comorbid autoimmune conditions. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.